So these are the learning objects, pharmacology of the different insulin preparations, indications for insulin therapy, and the plan, the choice of the regimens, various treatment algorithms for the type 2 diabetes. So they're all the same things. Already told you the Banting, orthopedic, West, MacLeod, Colip, and the first documented case of the Thompsons. So this is the December 15th, 1922. Is almost, if you don't give the insulin now, these people are going to die with the DKA. So February 15th. So after 2 months, Chabbi is still alive. That is possible only with the insulin therapy. See the before insulin therapy and then after insulin therapy, even 7 years later. So before the 1921, diagnosis of the diabetes means almost a death sentence. They hardly live for about 6 months. They used to die with the diabetic ketoacidosis or pneumonias or infections. So life expansion is possible with the insulin therapy. So these are all the insulin, different insulins. The first insulin 21 and 82 is a very remarkable year. Human insulins entered into the market at that time. So that is a very big change, a game changer. So earlier, no, it was the bovine insulins and the porcine insulins. So insulin produced from the beef and the pig. So the bovine insulin is about 3 amino acids different from the human insulin. And the porcine insulin is about 1 amino acids different from the human insulins. Both are having a lot of the side effects. Now with the introduction of your recombinant human technology, human insulin technology from the E. coli, so almost it is no side effects at all with the insulin therapy nowadays. And after that, we have the rapid acting insulin, long acting insulins, etc. So the last 25 or 30 years, so there's a lot of the insulins have entered into the market, which are making management of the hyperglycemia is very, very comfortable and very hypoglycemia free, because the most common complication of the insulin is the hypoglycemia. So with the newer analogs, the chances of having the hyperglycemia is very much reduced. So this is how the human insulin is derived from the E. coli. It is a conventional human insulin currently available are regular and the NPH. Regular insulin is a clear preparation, whereas the NPH insulin is the cloudy preparation. Regular insulin can be used through the IV, IM or subcutaneous, whereas the NPH insulin has to be used only subcutaneous, not as an IV or IM. Regular insulin starts acting 30 to 60 minutes, peaks at about 2 to 3 hours, and lasts for about 4 to 8 hours. So a snack may have to be taken at the time of the peak action as to prevent the hypoglycemia. Used as the prandial insulin, also called as the bolus insulin, as well as the diabetic ketoacidosis and other hyperosmolar hyperglycemic state. So these are the two acute complications of the hyperglycemia, diabetic comas. So the NPH is a cloudy, only subcutaneous, starts acting in 1 to 2 hours, peaks at 4 to 8 hours, and lasts for about 10 to 16 hours. Used as a basal insulin, either once or twice daily, but as they are having the peak, the chances of having the hypoglycemia in the midnight is very high. Premixed insulins, the consists of both the regular and the NPH insulins in the fixed dose 30 by 70, that means 30 units regular and 70% NPH. 25 by 75, 25 is the regular, 75 is the NPH. 50-50, so 50 is regular and 50 is the NPH insulin. Main advantage is the patient convenience, twice a day or once a day we give it. Disadvantage is no flexibility or the dose adjustment. What are the limitations of the conventional insulins? They do not mimic the basal or the physiological insulin profile. Okay, so the NPH insulin has a well-defined peak. Effect of the single injection does not last for 24 hours. Hence, not an ideal basal insulin. It has to be given twice a day in most of the cases. Regular insulin, so slower onset of the action, about 1 to 2 hours is the onset of the time. Has to be injected about 30 to 40 minutes or 60 minutes before the meals. Late the postprandial hypoglycemia, because its peak action is at about 4 to 6 hours. Hence, not an ideal bolus insulin, because it acts slow and then you don't cover the postprandial hyperglycemia peak, and that causes the postprandial hypoglycemia. So in view of the relatively low cost, regular NPH insulins will continue to be widely used in India. So these are the events of the subcutaneous injection. Already told you they are in the conventional insulins or in the hexameric forms. So they have to be converted to the monomers. So that takes a lot of the time in the subcutaneous tissue to the capillary membrane, and finally it enters into the circulation. These insulin molecules have the different pharmacokinetic properties from the conventional insulin produced by the altering its amino acid sequence. So I told you, proline, lysine, threonine, aspart. So these are all the Fias, lispro, aspart, glulisine. These are the ultra rapid acting, and long acting. See here. So the beta chain of the human, the first one is the normal one, constant in the 28, 29, 30 only. 28 is the proline, 29 is the lysine, and 30 is the threonine. What happens in the lispro? So just change the proline and lysine, replaced by the lysine and the pro. Okay. Aspart at the 28, proline is replaced by the aspartic. So that is aspart. Glulisine 29, lysine is replaced by the glulisine. So that is the glulisine. So these three, by changing the amino acid sequences, they became the analogs with less hypoglycemia and no peak. Advantage of the short-acting prandial insulin analogs, they have the 4 advantages. One is the better control of postprandial hyperglycemia because they act very fast. Fewer episodes of hypoglycemia, flexibility in the lifestyle, safer in the elderly, children, and the renal failure. So these are long-acting insulin analogs, the glargine, detemir, and the deglutec. So often we use the glargine and the deglutec. See here the glargine. 2 arginines are added to the B30. That is the glargine. You see the last one, B30. B30 chain, you add 2 arginines. That is the glargine. And the deglutec, same at the B30, is deleted and 16C fatty acid was added at the B30. So that is how the glargine and the deglutecs are formed. So this is the mechanism of the action. Precipitates slow dilution to the monomers. So insulin glargine is applied as an acidic formulation, pH 4, in the subcutaneous tissues at the pH of 7.4. Glargine forms microprecipitates, slowly dissolves over the time into hexamers and subsequently to the dimers and the monomers, which are absorbed into the circulation. So that is how this glargine will act for about 24 hours. Not even 24 hours, maximum is I think 18 to 20 or 22 hours. Not truly 24 hours. Detemir, we use a lot of the deglutec nowadays. So this forms multi-hexamers after the subcutaneous injection. So the glargine is microprecipitates. Here the multi-hexameric forms with the deglutex, from which it dissociates slowly into the circulation. Some degree of binding to the albumin, which further prolongs its duration of the action. So by this binding to the albumin, so they act for beyond the 24 hours, maybe 36 to 40 hours. What are the advantages of these basal analogs? One is the longer duration of the action compared to the NPH. It can be given once daily. Peakless, fewer episodes of hypoglycemia, especially the nocturnal hypos. Flexibility in the dosing, need not be given at the same time of the day every day, like a deglutec. Glargine, you have to give it every day same time because it hardly acts for about 18 to 20 or 24 hours. But whereas the deglutec acts beyond the 24 hours, you have the flexibility in timing also. So one day you can give it 8 a.m., 8 p.m., another day you can give it the 9 p.m., and sometimes you can give it 11 p.m., etc. So because beyond the 24 hours also there is some element, some amount of the molecule is there in our blood to take care of the basal hyperglycemia. So the main disadvantage is the cost, much more expensive than the NPH insulin. But India is one of the richest country. Even the 5% of the people can afford. So definitely a lot of the people are getting benefited with these analog insulins. So in India, you know both the sides of the coin. So poorest of the poor, you have the NPH insulin. Those people who can afford, you have the glargine and the deglutec because of these advantages. So this already I showed you slides. The first one is the rapid acting, and then the regular insulin, and then the NPH insulin, and finally the basal insulins. So same thing here. Onset of the action, peak action, duration of the action. Adverse effect is a very, very important adverse effect of the insulin is hypoglycemia. And sometimes, this hypoglycemia, very severe hypoglycemia, is almost close to the death also. So whenever you start the insulin, always go slow. Start low. That is very, very important. Otherwise, if you start with the very high doses of the insulin, so there is always a potential side effect of hypoglycemia. And this with severe hypoglycemia, they may change the allopathy to the homeopathy or positive homeopathy, and finally Tirupati. And most common and dose limiting side effect is the hypoglycemia, and less common with analogs. So obviously it is less common because they are peakless insulins. More likely in individuals with the co-prescribed insulin secretagogues. So when the fellow is taking the glimepiride or the Dionil or etc. So if the patient is also on the insulin therapy, so there are the chances of having the hypoglycemia in them. Renal insufficiency. So obviously the renal clearance will be very poor. So obviously the drug accumulated in the body. So there will be definitely hypoglycemia. And this hypoglycemia is also very prolonged hypoglycemia in CKD population. So once the creatinine is more than 1.5 or the 2, if the patient gets the hypoglycemia, you have to observe for at least 1 to 2 days or 3 days, because a prolonged hypoglycemia, rebound hypoglycemia is very common in CKD population. We have consumed alcohol. So alcohol definitely stops giving neoglucogenesis or glycogenolysis. So it makes the liver numb. So what will happen when the liver is not working properly? Your glycogenolysis and neoglycogenesis are at fault. So definitely when the fellow wants the blood sugar, so whatever the sugar is stored in the liver, that is not converting into the glucose and not entering into the blood. So these people will keep on getting the hypoglycemia. So that is the reason. Chronic alcoholics, so definitely there are chances of severe hypoglycemia with these drugs. Weight gain, not with the analog insulins, but with the traditional insulins, definitely weight gain. The weight gain is more when you are using the more shots of the insulin a day rather than the basal insulin alone. So when the fellow is getting the basal bolus therapy or 4 or 5 shots a day, so definitely the weight gain will be very, very high, because insulin causes more and more appetite. So the more appetite, so definitely more weight gain. So these are the side effects, not nowadays. It is with the bovine insulins and the porcine insulins. So your lipoatrophy and lipohypertrophy. So this is the very practical point. So the insulins are available in two strengths, 40 units and 100 units. So the 40 units, usually we use the 40 units. But once the patient's insulin is required more than the 30 units or 40 units or 50 units, so I have to go for the 100 units. So you have the two types of the syringes, red one and the black one. Red one with the 40 units and the black one with the 100 units. So both are 1 ml only. So this is 1 ml is 40 units. That is 1 ml is equal to 100 units. So I have to use the same syringes and the same vials here only. See what happens here. It is a 40 ml. Okay. We are using 100 unit syringe. So you are taking, suppose if the doctor advised 25 units, 25 units, and if they are using the 100 unit syringe, so it takes only 10 units or the 12 units. So the patient will get more and more hyperglycemia. So the reverse is also common. Suppose it's 100, the patient is taking the 40 unit syringe. So suppose the patient, he advised 50 units, and he will take very high and gets hypoglycemia. So the mismatch is very, very common. So that is the reason you have to see whether the patient is taking the same syringe and the same vial. So 40 units, this is the 40 units, he has to take the red syringe. If it is 100 units, he has to take the black syringe. So these are all the delivery devices. So nowadays, beautiful pens are available. They are more accurate dosing mechanisms are there, more convenient and easier, and improved compliance. So compliance has improved very lot with your syringes. So they are the pens are also available. The reusable syringes are also available. So LCD display to show the dosage setting. Dosage settings change quickly and very easily. And safety button automatically resets after the drug delivery. Insulin pump. So this is also very important. A continuous subcutaneous insulin infusion pump. It contains the reservoir, small battery, etc. Disadvantages: the high cost. Initial as well as the recurring cost. Every month they cost about 10 to 15,000. Success depends on the availability of the technical support. Intensive patient education and the motivation is very much required here. Indications: very high brittle diabetics, very high blood sugars, or pregnancy, or intraoperative, or post transplantation, or heart transplantation, or lung transplantation, or COVID diabetes, etc. So these are all important indications. Say a large proportion of the patients with type 2 diabetes will require insulin for maintaining the optimal glycemic regulation that is necessary to prevent the complications. So these are all not the patients, they are all the doctors. Central one is only physician. Central one is the physician, and the diabetologist is here, dermatologist is here, urologist is here, OBG is here. So every doctor should learn insulin therapy. Insulin therapy. So nowadays, diabetes is everyone's disease. Every doctor, whatever may be the specialty, except the forensic medicine, they should learn much about the diabetes. Indications for the insulin therapy. So these are our guidelines, RSD guidelines. In newly diagnosed patients who are symptomatic or have one of the following. Already told you these indications: type 1 diabetes, very elevated parameters, a positive ketonuria, that means urine ketone body is positive. Even the day one, today only you diagnose the diabetes, the blood sugar is 250 or 300, etc. And urine sugar shows ketone body is positive. So immediately have to start insulin only. So in ketosis, okay. And catabolic status, that means weight loss, more symptomatic. Okay, that is a catabolic state. Hospitalized patients not suitable for the OH. Most of the hospitalized patients who use only insulin only. Pregnancy or planning the pregnancy. So definitely the need for the insulin therapy. In patients with an already established diagnosis of the type 2 diabetes, that is OAD failure. So a trial of adequate doses of 2 or 3 non-insulin agents for 3 to 6 months fails to achieve the A1C target levels, or if organ dysfunction contraindicates use or intensification of the oral agents, addition of insulin may be justified. So all the OAD failure, so definitely there is option of insulin therapy. So one case study: a 45-year-old male bank executive meets you with a history of newly detected asymptomatic type 2 diabetes. So 45 years, asymptomatic. What is the fasting blood sugar? 326. Postprandial, post breakfast, not post lunch, post breakfast, 463. So he has been exercising regularly till 3 months ago, but follows a sedentary lifestyle now. Okay. So what would you advise to bring down his glucose levels? Insulin or oral medications? So before going to the insulin, so you have to examine him thoroughly, and you have to get the few investigations along with your fasting blood sugar, postprandial HbA1c, because he is asymptomatic, type 2 diabetic, 45-year-old male with very high blood sugars. So I told you earlier that 40 to 50% of the type 2 diabetics, they present with the complications at the time of the diagnosis itself. Okay, so that is the reason. So common comorbidities, you have to exclude them here. ABC. A is blood sugar, B is blood BP, C is cholesterol. So get the blood, check the blood pressure here. So whether it is 130 by 80 or less than 120 by 80 or more than 160 by 80, etc. So to rule out the hypertension, you have to check the blood sugar very properly here, blood pressure, and then the lipid profiles. So your HDL, your LDL, okay, your triglycerides, your non-HDL cholesterol, they are very, very important, because physical inactivity and high blood sugars. So maybe lipotoxicity. And then get an X-ray done. And then the ECG take. And take the urine albumin creatinine ratio to rule out the nephropathy or microalbuminuria. And then subject him for retinopathy, retina examination. So obesity, so BMI examination, waist circumference, waist hip ratio, skin fold thickness. So these are all the common investigations we needed along with your blood sugars, even on the day one, for such an individual, because just 45 years, bank executive, high blood sugars, very high blood sugars. Then you think of it. So what to do? So as your diagnosis is type 2 diabetes, there is always a big role for your lifestyle measures. So your dietary approach, your exercise. So as he is very sedentary, so give them the advice of the physical activity, importance of the physical activity. and importance of the dietary approach. And then what about the drugs? So don't use the sulfurious here. Okay. So you can go for the metformin, or you can use the GLP-1 receptor agonists like your oral semaglutide or the parental drugs, or you can use the SGLT2 inhibitors. And then finally, when the fasting is beyond 300, postprandial beyond 400, whatever may be the type of the diabetes, from the day one you have to start the insulin therapy, because it is in glucose toxicity. Glucose toxicity. For the glucose toxicity, what is the antidote? Insulin. So you have to start the insulin. So that you should remember. On the day one of the case, whether the fellow is in the toxicity or non-toxicity. When the patient is in the glucose toxicity, whether type 1, type 2, other things, you just give the insulin, make him comfortable, get the blood sugars come to the normal levels, then you can change over to the OHS, provided if the case is the type 2. Already they diagnosed type 2 diabetes only. Okay. So what are the barriers to the insulin therapy? There are the physician's barriers and also the patient barriers. So the patients, once on insulin, I will get addicted to it. Very common. Insulin is the last tool to use. Insulin means frequent hypos. No doctor, give me 1 more month. I will show you. Once on insulin, always on insulin. So these are all the patient barriers. You have to tell them that, see, in type 2 diabetes also we need insulin. So once on insulin means not on lifetime insulin. So again, you have to change out to the OHS at a near future. So you have to clarify these doubts. These are all are myths. Doctors, insulin has many side effects. Even most of the doctors, they are worrying about initiating the insulin therapy. So we should be very careful, and we should be very strong enough to start the insulin therapy when the situation demands. If you don't show good control, next time I will put you on insulin. So a punishment to the patient and also the guilt. So we should not say like that. So that is the reason for all the diabetes on the day one, whether it's a type 2 diabetes also, we should address the importance of the insulin in them. So you may need insulin in the near future, provided the sugars are not under good control, even though the diagnosis is the type 2 diabetes. What are all the other barriers? A fear of hypoglycemia, so that can be controlled if you start low dosages and slowly. Pain and needle phobia, that is not there with the 31 gauge needles, very, very painless needles. Inconvenience, it's not inconvenient because nowadays the good pens are there, insulin pens are available. Non-realization of the seriousness of the consequences of the diabetes is very important. So you have to tell all the complications of the diabetes, complications of the uncontrolled hyperglycemia. So what will happen? Fear of weight gain. So provided if the patient is on good physical activity and good dietary approach, so with your metformin, with your SGLT2 inhibitors, or with your basal insulins, I think weight gain is not there. Need to monitor the blood glucose more frequently. Yes, sometimes we have to monitor. Now the glucometers are available. False belief that insulin is only for the serious cases. It is not for only serious cases. It is not. It is for to prevent the seriousness of the diabetes. Okay. If you don't use the insulin at the right time, so the case will be serious in the near future. So to prevent the seriousness, we have to use the insulin. So start low and go slow. Frequent titration and doses based on the self-monitoring of the blood glucose. Patient education is a must. This is very, very important. Which regimen do I start with? There the options are there. Already told you the basal insulin or the premixed insulin, basal plus. So that means basal insulin plus 1 regular insulin, and basal bolus is the short safety insulin. This is a case study to 3 patients with a secondary failure to oral hypoglycemic agents. So very commonly we use a lot of the oral hypoglycemic agents, and still the blood sugars are very high. So these are the 3 such cases. Case 1, fasting 130, postprandial 240. Case 2, fasting 240, postprandial 280. Case 3, fasting 260, postprandial 360. So what insulin regimens would you use for these 3 cases? So how to use the insulin, because all the OHS are failure. So these are the blood sugar levels. Case 1, Anand. ఏదో చెప్పు మాట్లాడు, ఏదో ఒకటి మాట్లాడు. ఇన్సులిన్ చేయాలి, ఇన్సులిన్ పెట్టాలి. వాట్ ఎవర్ ద ఫాస్టింగ్ అండ్ ద పీపీ? ఫాస్టింగ్ ఈజ్ ఇట్ హై ఆర్ postprandial is high? Do you need any insulin to reduce the fasting here? Okay, right. That is the right answer. So we don't need any insulin for the reduction of the fasting here in case 1. So we need an insulin to reduce the postprandial blood sugar. So what type of insulin you use? Basal insulin? Not basal. Not basal. Only prandial insulin, regular insulin. Regular or prandial. Not basal. Maybe the bolus or the prandial or the regular. So am I clear? So whenever you see such blood sugars, you ask yourself whether the fasting is more or postprandial is more. When the postprandial is more, how to reduce the postprandial hyperglycemia? Not with the basal insulin. Basal insulin will reduce the fasting blood sugars. Okay. So your prandial insulin or your regular insulin will reduce the postprandial blood sugar. So give one shot of actrapid or your lispro or your aspart here. Maybe 4 units or 5 units or 6 units or 10 units. So that will take care of the postprandial blood sugar here. Case B, fasting blood sugar 240, postprandial blood sugar 280. Dinesh. So ask yourself, fasting is more or PP is more? Yes, both are more. But which one is much more? So fasting is much more than the postprandial. So which insulin you use? Excellent, excellent. So use the basal insulin to reduce the fasting blood sugars. So maybe I told you the FF rule. Okay, fix the fasting first. So wait for 1 month or you wait for the 2 months. Advise him good dietary approach. Advise him good physical activity. Just add basal insulin. Very simple. Maybe 10 units or maybe 7 units or maybe 12 units or 7 or 12 depends on the weight of the patient. Maybe 0.1 to 0.2 units per kg body weight. Suppose the person is 70 kgs, you can start with 7 units. If you think that 0.1 is sufficient, or 0.2 units means 14 units. Otherwise, just give 10 units of the basal insulin. Wait for 2 days, 3 days, get the fasting blood sugar, and then the so okay, what is the dose of the basal insulin you start here? Say 10 units. Okay, 10 units. So when you check the fasting blood sugar again, good after 3 days. Okay. So after 3 days, the blood sugar is 220. So what to do? Dinesh is answer. 220. After 3 days, the fasting blood sugar is 220. You start with 10 units. Good, excellent. So you have to up titrate or increase the dose. So after 3 days, the blood sugar is 140. Maybe somewhere increase, no problem. So your target is 120. Okay, your target is 120 or 130. So increase another 2. So after 10 days or 5 days, the blood sugar is 100. So what to do? Maintain the same dose. Suppose after 3 days or 1 week, the blood sugar is 80. So what to do? Give him big hands. Okay, so that's how we have to treat the difference. Here the fasting is much more than the postprandial. Okay, fasting 240. Your goal is 100 or 120. That means almost double the height. Suppose we here see the postprandial 280. So your goal is maybe 180 or 160. So here hike is only 100, but there the hike is nearly 140 or 150. So give more of the fasting blood sugar here. So you add the basal insulin. Once in 2 days or 3 days or 4 days, check the fasting blood sugar. You can up titrate or down titrate according to the your fasting blood sugar to reach your euglycemia. What about the C? C. Or Simhadri, stand up. Okay, see, fasting and postprandial. So which one? What is your impression here? First question, which one is higher? Both are much higher. So how to treat? When the fasting and postprandial both are very high, how to treat? Basal, night basal insulin to control the fasting blood sugars. Okay. Regulates. How many shots you give? 3 shots. So that is the one option. Suppose why don't you use the mixed shots here? So that controls both the fasting as well as the postprandial. That is very easy to administer. So very patient convenience. Okay. So the first you go for the mixed starts here. Okay. So give the maybe 20 units or 30 units morning time and maybe the 10 or 15 units at the night time. So usually 1 unit per kg body weight. Okay. If the person is about 40 kgs. Okay. he needs nearly the 70 units. Or if you want to start with the low doses, you can start with 1/5 of the doses, half of that doses, maybe 35 units or 40 units. So when the 40 units is the maximum dose per day, 2/3 in the morning and 1/3 in the evening. Okay, so in that way you can start it. Good, very good. So that's how you have to treat the, you have to initiate the insulins. When the fasting is much more when compared to the postprandial, start with the basal insulin. When the postprandial is much more compared to the fasting, you start with the prandial insulin. When both are very much elevated, you can start with the basal bolus or with the mixtars. Mixtars. So mixtars is much more practical and very easy to administer. Suppose if the patient is educated and he is well versed with the glucometer and he is very confident of getting the blood sugars very good. So then our first choice should be towards the basal bolus therapy only, because that is the most physiological way of treating the hyperglycemia. Good. Now the case study 3. Here the male type 2 diabetes and metformin 1500 mg, glimepiride 4 mg, sitagliptin 100 mg. His weight is 72 kgs. Fasting 243, PP 282. After discussing all options, he is willing to start the insulin. So what is insulin will you use? What is the starting dose? So he is under 3 drugs. So he is on 3 drugs. 3 is also maximum ultimate doses. Metformin 1500 mg, glimepiride 4 mg, and sitagliptin 100 mg. He is on the maximum tolerated doses of the 3 drugs. And weight is also 72 kg. This is not obese. Not that obese. Okay, 72 kgs is. Fasting blood sugar 243, PP is 282. When compared to the postprandial and the fasting is much more than the postprandial. So after discussing all options, he is willing to start the insulin. So which insulin? Good. So when you want to start the insulin, I think the basal insulin is the best way of treating here. Here the fasting is much more than the postprandial. Then only option to start here is the basal insulin. How much you start? 10 units. So when to get then again the fasting blood sugar? 3 days. You can update it, down it. That's that. What is the starting dose? So 10 units are 0.1 to 2 units per kg body weight. Will you continue OHA? Yes, continue the OH only. All OHs you have to continue. So that you have to continue the same all. So you are adding the basal insulin to control the blood sugar. Suppose if you stop giving the OHs and only the basal insulin, it is very difficult to control it. So then you can go for the basal bolus therapy. Basal bolus. So bedtime insulin in combination with the current OADs, that is the basal insulin. So bedtime insulin, basal insulin in combination with the already whatever the OHS is getting it. Most of the Western guidelines recommend to stop the secretagogues. However, it is often noted that control of postprandial hyperglycemia is very difficult without using a secretagogue even after initiating the basal insulin. A reasonable approach would be to continue the secretagogues even after the basal insulin is started, like the glimepiride 4 mg in the earlier case, and stop them when the prandial insulin is initiated. This combination of the metformin with insulin is recommended by all the guidelines. So all the guidelines, they say that metformin continue along with the insulin, because metformin take care of the insulin resistance part. Titration of the basal insulin. Yes, this already I told you. Now the case study. Female, 54 years. Type 2 diabetes for the last 15 years. Okay. She is on glycoside, 160 mg a day, metformin 2000 milligrams a day. Her BMI is 32 kgs. So she is obese. She is not able to tolerate the incretin-based therapies. So incretin-based therapies means 2 types. GLP-1 receptor agonists may be injectable like dulaglutide, etc., or oral semaglutide like ribelsus. On the other hand, DP4 inhibitors. So you have the sitagliptin, veldagliptin, etc. So she is not able to tolerate. Why? Because of the side effects. What side effects you have? You have the nausea, vomiting, upper respiratory tract infections, etc. Or some people they may develop the arthralgia. Some people they develop the rash. So these are the side effects of these gliptins. Now the fasting is 268, PP 344, A1C 11%. How will you manage this patient? So this is the diabetes. So she is a diabetes plus obesity. Is perimenopausal or postmenopausal. Okay. Glycoside 160 milligrams, metformin 2000 milligrams. So straight away you can have options. Okay, number one, the patient is on sulfonylurea, the patient is on metformin. So other option is you can start with the pioglitazone. Okay, pioglitazone. Is it indicated or not indicated here? Not indicated, because pioglitazone will cause body weight, will cause edema, will cause osteoporosis, especially postmenopausal women. So pioglitazone out. Number 4, your oglibose, alpha glucose inhibitors are there. So oglibose will reduce the postprandial blood sugars alone. How much? Maybe 20 milligrams or 40 milligrams. What is the post PP here? 344. What is your goal? Maybe 140 or 160 or 180. So nearly 200 difference is there. So 200 milligrams reduction is not possible with your oglibose. So that is also out. And then GLP-1 receptor agonists. They are very good to reduce the body weight also. But that is incretin based therapy, not tolerating. And sitagliptin or veldagliptin, saxagliptin, they may be useful. But again, they are not tolerating here. And then SGLT2 inhibitors. SGLT inhibitors are also very good choice here, because they reduce the body weight. They are independent of the pancreatic action. So they can be added to here, because to reduce the obesity, to improve the glycemic control, and to have a renal and also cardiac protection. So is the SGLT inhibitor is sufficient? Alone is sufficient here. So how much HbA1c reduction you can expect with the SGLT inhibitors? 1 to 1.2%, maximum 1.4%. But what is the hike here? 14%. What is your goal at 44-year-old female? Maybe 6.5, less than the 7. 6.5 between 7. Suppose even 7 anukunna sare, there is a 4% reduction in the HbA1c you should achieve. Is it possible with SGLT inhibitors alone? Not possible. So now the answer is that's how you have to think of any case. So when the patient is on some particular drugs, why not that drug? Why not this drug? Why not that drug? Why not this drug? Finally, why not insulin? So that's how you have to go for the insulin therapy. So here you can start with SGLT inhibitors. So what about the glycoside? What about the glycoside? See the weight. She is obese. So sulfonylureas usually cause more weight gain. So when you are starting the SGLT inhibitors, I think you can stop using glycoside. You can stop and you can add SGLT inhibitor instead of the glycoside, and then you can add the insulin therapy here. So which insulin you use here? Good. So a premixed insulin is an ideal choice, because it is both fasting as well as the postprandial. Or if the patient is affordable or uneducated, even the basal bolus is also good. See 1 or 2 injections of premixed insulin before meals. Advantages: better control of postprandial than with basal only regimen. Convenient and more acceptable to the patient than the basal bolus regimens. Disadvantages: more chances of hypoglycemia. I told you now, especially the post lunch or before the dinner. Less flexibility. So this is the multiple daily injections. That is the basal bolus therapy. Patients may require a total dose of 0.8 to 1 unit per kg body weight. So now you have to calculate the total dose of the insulin. Usually remember 1 unit per kg body weight. So fellow 70 kgs. How much insulin he needed? 70 units. 70 units. So if you want to use the basal bolus therapy, 50% or 40% use it as the basal insulin. Out of the 70 units, you get 50% is the 35. So you can use 25 to 30 units as the basal therapy. Suppose 30 units you are giving the basal insulin, so 40 units are left. That 40 is divided into 3 prandial insulins. So out of the 40, you can give 20 as the lunch, and about 5 to 8 or 9 units before the breakfast, and about 12 or 13 or 14 to the dinner. That's how you have to adjust the dosages. Am I clear? So when you are planning for the basal bolus therapy, what is the weight of the patient? So 1 unit per kg body weight, that is your total dose of the insulin he requires. And about 50% or 40% is the basal dose, basal insulin. So remaining 60% or the 50% is your prandial dose. So that we divided into 3 groups. So breakfast, lunch and the dinner. So ask the patient, which one is high calorie diet? So for me, the lunch is the high calorie diet. And next one is the dinner, maybe the very little breakfast. So some people, the more is the brunch, breakfast time, and then very little at the lunch, and very little with the dinner. Some people know more with the dinner, and then very little with the insulin, and very little with the breakfast. So depending on the patient's profile, So you can divide this prandial insulin in these different ways. Okay, am I clear? So that is how you have to start with the basal bolus therapy. So check the weight of the patient. So and that much of the units he requires a day, and then divide into as the two groups. One is 40 to 50% the basal insulin, and 50 to 60% as the prandial insulin. Again, the prandial insulin you have to divide into three groups. Book says the three equal halves. That's not correct in our Indian diets. Okay, say because our breakfast may be 300 calories, maybe our lunch may be the 1400 calories or 1000 calories, and dinner may be the 400 or 500 calories. That depending on the calorie intake, you have to adjust the doses of the insulin. That is the best way of avoiding the hypoglycemia. Otherwise, 10 units breakfast, 10 units lunch, 10 units dinner. This 10 units of the lunch may not sufficient. So the people will have the hyperglycemia. The 10 units of the breakfast is much more. He may get the hypoglycemia before the lunch. Okay, so we should avoid the hypoglycemia before lunch, hyperglycemia before dinner. So by adjusting the 6 or 7 units in the breakfast and about 12 or 14 units in the lunch time, so you can avoid the hypoglycemia and you can avoid the hyperglycemia also. So that is your patient profile, and your relation of the patient will tell you how much amount of the insulin has to be used before the breakfast or before the dinner breakfast. So am I clear? So I told you very clearly about the usage of the basal insulin as the 10 units and adjust with the fasting. That is you are all become the masters in that. And now as the basal bolus therapy. So stop all the OHS, only insulin. So that is how you have to give the basal bolus therapy. Okay, sir. All the way from Palakul. Now adjustment to the insulin injections. See the persistent hyperglycemia after breakfast. So what to do? Persistent hyperglycemia after breakfast. So increase the morning fast acting insulin by 2 units. Okay. Understood? So the fellow's blood sugar post breakfast is 300. So that is persistent hyperglycemia after breakfast. So ఎలా కంట్రోల్ చేస్తాం? బ్రేక్ఫాస్ట్ తర్వాత 300 milligrams ఉంది blood sugar. Before the breakfast you are giving regular insulin. Just increase the dose so that it will take care of the post breakfast hyperglycemia. Am I clear? Okay. Suppose after lunch, persistent hyperglycemia after lunch. So what to do? So increase the regular insulin before the lunch. Before the lunch. This is a very important. Okay. So unexplained hypoglycemia after the breakfast. What to do, Dinesh? After the breakfast, getting hypoglycemia. You are giving regular insulin before breakfast. So what is the dose of the regular insulin? There. Increase or decrease? Decrease. Absolutely. So after the lunch, getting hypoglycemia. Decrease the dose before breakfast or before lunch? Before lunch. So that is right answer. So these are the practical points. Okay. Persistent hyperglycemia after dinner. So what to do? After dinner, persistent hyperglycemia. Before the dinner, you are giving regular insulin. Yes, increase the evening fast acting insulin by 2 units. Suppose before breakfast, hyperglycemia. That means fasting hyperglycemia. You are right answer. So basal increase. Unexplained hypoglycemia after dinner. So 10 o'clock, 10 p.m. before bedtime, getting hypoglycemia. Before the dinner, you are giving 8 units or 10 units. Getting hypoglycemia 10 before bedtime. So reduce the regular insulin or the fast acting insulin before the dinner. And then unexplained hypoglycemia before breakfast. Reduce the basal insulin by 2 units. Okay, that's how. So this is a case studies 5. Male, 55-year-old, type 2 diabetes of 16 years duration, is an injection premixed human insulin, 30/70, 30 units before the breakfast, 24 units before the dinner. How much is getting? Breakfast 30, before dinner 24. Per day he is getting 54 units. He comes to you with an HbA1c of 8.5%. SMBG readings are as follows. Day 1, fasting 107, post breakfast 155. Are you happy? Good. Day 2, before lunch 61, after lunch 256. Are you happy? Not happy. Both ways you are not happy. Before lunch getting hypoglycemia. After lunch hyperglycemia. Yes, very good. Day 3, post breakfast 149. Happy. Before dinner 206. More. More. Before dinner more. Okay. పోనీ ఇక్కడే చెప్పేసుకుందాం. ఏమంటారో మన రెమెడీస్ కూడా. Go to the second case. So before lunch 61. That means you are getting hypoglycemia. Okay. He is getting insulin. How much insulin is getting morning before breakfast? 30 units. So what to do? 30 units he is getting before breakfast. Getting lunch before lunch hypoglycemia వస్తుంది. So answer is you have to reduce it. Okay. Reduce చేసాం అనుకోండి 30 నుంచి ఎంత తగ్గిస్తాం? These are practical points. ఓకే ఓకే 2 యూనిట్స్ తగ్గించాం. తగ్గిస్తే ఎంత ఉంది? రెగ్యులర్ ఎంత ఉంది, అందులో లాంగ్ యాక్టింగ్ ఎంత ఉంది? సపోజ్ 30 యూనిట్స్ ఇస్తున్నా 9 యూనిట్స్ ఇస్ రెగ్యులర్. 9 యూనిట్స్ రెగ్యులర్. 10 యూనిట్స్ కి 3 యూనిట్స్ రెగ్యులర్, 7 యూనిట్స్ లాంగ్ యాక్టింగ్. సో 30లో 9 యూనిట్స్ ఇస్ ద రెగ్యులర్. 9 మైనస్ 30 మైనస్ 9 అంటే 21 యూనిట్స్ లాంగ్ యాక్టింగ్. సో అక్కడ 9 యూనిట్స్ రెగ్యులర్ ఏమో ఎక్కువైపోయింది కదా, అందుకని యూఆర్ గెటింగ్ హైపోగ్లైసిమియా. బట్ లంచ్ తర్వాత ఏమైంది? 61 తర్వాత హైపోగ్లైసిమియా. నువ్వు వచ్చా 21 యూనిట్స్ సరిపోవడం లేదు. ట్రిక్కీ సిచ్యువేషన్ అబ్జర్వ్ చేశారా? ద మార్నింగ్ యూ ఆర్ గివింగ్ మిక్స్చర్, ఇట్ కంటెన్స్ రెగ్యులర్ ఇన్సులిన్ అండ్ ద NPH ఇన్సులిన్. రెగ్యులర్ ఇన్సులిన్ ఏమో 9 యూనిట్స్ ఇస్తున్నాము, 21 యూనిట్స్ ఏమో లాంగ్ యాక్టింగ్ ఇస్తున్నాం. 9 యూనిట్స్ రెగ్యులర్ ఇన్సులిన్ ఇస్తేనేమో హైపోగ్లైసిమియా వచ్చేస్తుంది బిఫోర్ లంచ్. తగ్గిస్తాం అనుకుంటున్నాం. తగ్గిస్తే దాంతో పాటు నువ్వేం చేస్తావు? ఏం తగ్గిస్తావు? లాంగ్ యాక్టింగ్ కూడా తగ్గిపోతుంది. నువ్వు 30 నుంచి 25కి వచ్చావు అనుకోండి, 24కి వచ్చావు, అది తగ్గిపోతుంది. ఇప్పుడున్న 21 సరిపోవడం లేదు అక్కడ పోస్ట్ లంచ్ కి. సో అదనమాట. అప్పుడు ఏం చేయాలంటే మనం ఏం చేయాలంటే అర్థమైంది. సో ఆ కాంబినేషన్ మార్నింగ్ మిక్స్డ్ ఇవ్వడం వల్ల వర్క్ లేదు, పని చేయడం లేదు. ఓకే, అలాంటి మిక్స్డ్ మనం డివైడ్ చేసేసి రెగ్యులర్ ఇన్సులిన్ ఇచ్చుకోవాలి. రెగ్యులర్ ఇచ్చినప్పుడు ఎంత ఇస్తున్నాం? మనం ఎంత ఇస్తావు బ్రేక్ఫాస్ట్ కి ఈ పేషెంట్ కి రెగ్యులర్ ఇన్సులిన్? 10 అలాగే ఇస్తావు. 9కే నీకు హైపోగ్లైసిమియా వచ్చేస్తుంది కదా, అర్థమైందా? సో రెడ్యూస్ లెస్ దాన్ 9. దట్ ఈస్ యువర్ ఐఎమ్ గివింగ్ ద గోల్స్ అంతే, మీకు వే చూపిస్తున్నా. ఎంత ఇస్తావు అనేది నీ ఇష్టం, బట్ ఇట్ షుడ్ నాట్ మోర్ దాన్ 9. ఇట్ షుడ్ నాట్ బి 9 ఆల్సో, బికాస్ 9 ఆఫ్ యువర్ రెగ్యులర్ ఇన్సులిన్ కాజింగ్ హైపోగ్లైసిమియా. అది 8, 7, 6 ఇట్ ఈస్ యువర్ కన్సిడరేషన్, బట్ ఇట్ షుడ్ బి లెస్ దాన్ ద 9. ఓకే. అండ్ దెన్ ఇప్పుడు 21 కదా మనం లాంగ్ యాక్టింగ్ అక్కడ ఇస్తున్నాం. ఇప్పుడు బిఫోర్ లంచ్ ఎంత ఇవ్వాలి రెగ్యులర్? లాంగ్ యాక్టింగ్ అని మరి దానికి మనం చేసుకోవాలి కదా జాగ్రత్తగా. ఇప్పుడు మాధవి చెప్పింది అబ్సల్యూట్ రైట్. నీకేంటంటే బ్రేక్ఫాస్ట్ టైంలోని మనం బ్రేక్ఫాస్ట్ ఇస్తున్నాం. బ్రేక్ఫాస్ట్ టైంలో ఎంత ఇస్తున్నాం మనం? ఇక్కడ 9 యూనిట్స్ ఇస్తే 61 వచ్చింది. సో హియర్ యూ షుడ్ అసెస్ ద క్యాలరీ ఆఫ్ ద బ్రేక్ఫాస్ట్ అండ్ క్యాలరీస్ ఆఫ్ ద లంచ్. ఓకే, సపోజ్ క్యాలరీస్ ఆఫ్ ద బ్రేక్ఫాస్ట్ అండ్ క్యాలరీస్ ఆఫ్ ద లంచ్ ఆర్ ద సేమ్ అనుకోండి. సపోజ్ 9 యూనిట్స్ నీకు హైపోగ్లైసిమియా వస్తున్నప్పుడు 8 ఇస్తున్నప్పుడు ఇక్కడ 8 అవ్వాలి. బట్ మనకి యూజువల్ గా లంచ్ ఎక్కువే ఉంటుంది. సపోజ్ బ్రేక్ఫాస్ట్ కన్నా డబుల్ ఉంది అనుకోండి లంచ్, అక్కడ మీరు 8 యూనిట్స్ ఇస్తున్నారంటే 16 యూనిట్స్ సరిపోతుంది. లేదు బ్రేక్ఫాస్ట్ కన్నా 1.5 ఉంటుంది అనుకోండి లంచ్, అక్కడ 8 ఇస్తుంటే ఇక్కడ 12 సరిపోతుంది. Am I clear? So that's how you have to adjust that case అనమాట. అది that is the second. ఓకే, థర్డ్ డే చూడండి. థర్డ్ డే పోస్ట్ బ్రేక్ఫాస్ట్ is 149 is okay. Again before dinner 206. సో మనకి లాంగ్ యాక్టింగ్ సరిపోవడం లేదన్నమాట ఈ కేసులో. అందులో ఎలాగో మీరు బిఫోర్ లంచ్ ఎలాగో ప్రాండియల్ ఇస్తున్నాం కాబట్టి సరిపోతుంది, అంతే ఈ కేసులో. సో హియర్ యువర్ మిక్స్డ్ నైట్ టైం మిక్స్డ్ కంటిన్యూ చేసుకోవచ్చు. ఎందుకంటే ఆల్ ద 3 వాల్యూస్ ఆఫ్ ఫాస్టింగ్ 107, 98, 102. సో మీరు ఇచ్చే 24 యూనిట్స్ ఇస్ సఫిషియంట్. నైట్ డిన్నర్ కి ఇచ్చే మిక్స్డ్ ఈస్ వర్కింగ్ వెల్ బికాస్ యువర్ ఫాస్టింగ్ ఈస్ గుడ్ అండ్ నో హైపోగ్లైసిమియా ఇన్ ద నైట్ టైం. సో కంటిన్యూ ద మిక్స్డ్ at the night time, but instead of giving the 30 units in the morning, you can give 2 shots before the breakfast and before the lunch, as our Sharmagar is saying that no rapid, not act rapid. Okay, now this is the case, another case. Male, type 2 diabetes, for the past 25 years. His height is 168 and weight is 65 kgs. He is on premixed 30/70, 30 units in the morning and 15 units at the dinner time. Fasting blood glucose 114. His blood glucose 2 hours after the breakfast is 238. Okay. He complains of symptoms of hypoglycemia in the evening. A1C is 8.8. So tricky situation. So he is getting insulin. How much? 30 units in the morning and 15 units in the dinner time. And is whatever the fasting blood sugar, good control, 114. Is not getting the hypoglycemia in the night time. So continue the 15 units of the bedtime is, that's how you have to think of the case. Okay, case study. So what about this post breakfast hyperglycemia? So post breakfast is getting hyperglycemia, and hypoglycemia at about evening time. Evening time. Okay. His HbA1c is 8.8. His H1 is 8.8. So you have the two options here. One is you have to increase the dose of the morning breakfast. So మార్నింగ్ బ్రేక్ఫాస్ట్ ఇంక్రీజ్ చేసామనుకోండి, ఇన్సులిన్ ఇంక్రీజ్ చేస్తే పోస్ట్ బ్రేక్ఫాస్ట్ తగ్గొచ్చు. బట్ వాట్ ఎవర్ ది ఈవినింగ్ హైపోగ్లైసిమియా అది ఇంక ఇంక్రీజ్ అయిపోతుంది. అంతే కదా, లాంగ్ టర్మ్ లాంగ్ యాక్టింగ్ ఇన్సులిన్ ఉంది కదా అందులో. మురళి గారు పాయింట్ అర్థమైందమ్మా? సో ఇనిషియల్ 30 units యూ ఇంక్రీజ్ 35 units ఫర్ ఎగ్జాంపుల్. సో 35 units ఇంక్రీజ్ చేస్తే నీకు రెగ్యులర్ ఎక్కువైపోయింది కదా. That regular will take care of the post breakfast hyperglycemia. So that will be reduced. But whatever the evening time, no, almost long term got increase changes now. So much more hypoglycemia. So that you should tackle this. So again, by changing the to your Novo Rapid or Fias. So that's how we can control the HbA1c also. 8.8. Okay. So this 8.8 is because of your post breakfast hyperglycemia. So once you control the post breakfast hyperglycemia with your regular insulin, so obviously that 8.8 also will come down to maybe 7 or 6.5. This is a good slide. Now patient A and patient B. See the fasting blood sugars. Are they normal or high? Both the cases? Both the cases. Okay. See the postprandial. Second one, postprandial. Are they normal? First case? Near normal. Okay. Second case? Okay, not bad. See the 3 a.m. blood sugars. First case? Hypoglycemia. Second case? Hyperglycemia. This is a very, very important practical point. If you see the fasting blood sugar of both the cases, fasting blood sugars are very high. And if you see the 3 a.m. blood sugar, in one case it is hypoglycemia, in another case it is hyperglycemia. So this is Somogyi phenomenon, that is Dawn phenomenon. Okay. So what is the answer here? This case. So if you increase the dose, basal insulin, so what will happen to your 3 a.m. blood sugar? Still it comes down. So second case, if you increase the basal insulin, that will take care. Okay. So to increase the dose or not to increase the dose, you have to see the 3 a.m. blood sugar also to rule out the Dawn phenomenon or Somogyi phenomenon. So Dawn phenomenon is nothing but post hypoglycemic hyperglycemia. But fasting is high. This fasting is high because of the hypoglycemia inducing hyperglycemia. Post hypoglycemic hyperglycemia. So in the situation of the hypoglycemia, the counter regulatory hormones will release. Your glucagon, your cortisol, your thyroid, etc. Growth hormone. So they will increase, and counter regulatory hormones will increase the blood sugars. So that is the reason for this blood sugars. So this hyperglycemia is because of the post hypoglycemic hyperglycemia. So there, that hyperglycemia is a routine hyperglycemia. So there we have to increase the more and more insulin. Here you have to reduce the low and lower insulin. Suppose if you reduce the basal insulin here, you are avoiding the hypoglycemia. So once you are avoiding the hypoglycemia, this also will come down. This also will come. So this is a Somogyi phenomenon, rebound hypoglycemia following the nocturnal hyperglycemia. See, these are the salient features. Another 5 to 10 minutes I am going to stop. Glycemic targets and the glucose lowering therapies must be individualized. Okay, they are all individualized. These guidelines are there to guide you, but the treatment must be individualized. Diet, exercise, education, they are very, very important pillars. Out of the 4 pillars of the diabetic management, one pillar is diet, One pillar is exercise, another pillar is education. The drugs is only one pillar. So the drugs, your doctor role is only 25% in the management of the diabetes. So diet, exercise, medication, or meditation or yoga or education. So 75% is the patient's involvement. So for most individuals with type 2 diabetes, metformin, obviously the first one, unless otherwise contraindicated like CKD, etc. GLP-1 receptor agonists and SGLT inhibitors are preferred first line agent nowadays. So now the treatment is individualized. Earlier the treatment is glucose centric. So we have to reduce the blood sugars only. Now whenever you see a patient, whether it is a simple diabetic or a complicated diabetic, or a people at risk of atherosclerotic cardiovascular disease, or at a risk of heart failure, or at a risk of CKD. So then your treatment varies. So in such situations, I think SGLT inhibitors is the preferable drugs, even as a initial line of the management. So above your metformin also in some cases. See, after metformin, there are limited data to guide us regarding the choice of the second line agent. Combination therapy with an additional 1 or 2 oral injectable agents is reasonable, aiming to minimize the side effects where possible. Ultimately, many patients will require insulin therapy alone or in combination with other agents to maintain the glucose control. All treatment decisions, where possible, should be made in conjunction with the patient, focusing on his or her preferences, needs, and values. Comprehensive cardiovascular risk reduction must be a major focus of the therapy. That is very, very important. Comprehensive cardiovascular risk reduction and also renal risk reduction, because CKD is also very common in diabetic individuals. So this already I told you, atherosclerotic risk or heart failure risk or the CKD risk, where SGLT inhibitors or GLP-1 receptors are the drugs of the choice. Questions to be asked before choosing a new agent. Does the drug address the basic pathophysiological mechanism? Already I told you the omnious octet. Okay, whenever you see a patient, whenever you use a drug, so this drug acts at the liver or the muscle or adipose tissue or at the level of the kidney or at the brain or alpha cells or beta cells or at the intestines. So these things you should remember that. So don't use the 2 or the 3 drugs of the same class. Sometimes we see the prescriptions seeing that glimepiride in the morning or glycoside in the afternoon and then the glibenclamide or the glipizide at the night time. So 2 or 3 sulfonylureas in a single patient is always bad. So the metformin and the pioglitazone, again the pioglitazone 3 times and metformin 4 or 5 times, the only maximum doses of the metformin pioglitazone, that also won't help you because both the drugs will act at the level of the liver, muscle and adipose tissue. So if you want to add the drugs which can act in a different way so that you will have a synergetic effect. So does it have effects beyond the glycemic control? That is very important. So beyond the glycemic control means any drugs which acts on the fatty liver, drugs which can reduce the renal burden, drugs which can improve the endothelial functions, or drugs which can reduce the lipid profiles. So these are very important. So to reduce the vascular risk, so extra glycemic benefits should also look for that. For example, the SGLT inhibitors, so they are renal friendly or cardiac friendly. Suppose you are using the gliptins, so they are the neutral, cardiac neutral. So such things you should take into consideration. Does it have any unique properties? Does it have utility in the special situations like elderly, hepatic, renal, and cardiac insufficiency? Suppose the cardiac insufficiency, the patient is taking the saxagliptin, so better to avoid it. If the patient is taking the pioglitazone, so better to avoid it. If the patient is taking the long-acting sulfonylureas like glibenclamide in a cardiac patient, so better to avoid them. Suppose the patient is on the CKD population, so using the metformin higher dosages, so always bad. We have to reduce the doses of the metformin. Suppose the patient is taking the sitagliptin in the maximum doses, 100 milligrams, in a CKD population with the creatinine level of 2.5 or the 3. So that is not good. You have to change out to the linagliptin, or you have to reduce the sitagliptin dose as maybe 50 mg or 25 mg, depending on the GFR. So these are the adjustment in the doses also must be seen. In elderly population, don't use the sulfonylureas, they cause hypoglycemia. In hepatic, don't use the vildagliptin, which acts at the level of the liver. And the renal I already told you, cardiac also I already told you. So these things are very, very important. Lack of the toxicity, should know all the side effects of the drugs. Need for the additional monitoring. Is the drug weight neutral or weight gain or weight loss? Does it cause hypoglycemia when used as the monotherapy? So drugs which won't cause hypoglycemia are the metformin, SGLT inhibitors and the gliptins. Which cause hypoglycemia are the sulfonylureas and the insulin. weight gain is the pioglitazone and insulin are the weight gain molecules, sulfonylureas. Is there possibility of using the combination therapy? Most of the drugs, so your metformin can be combined with all the drugs. Your voglibose can be combined with the most of the drugs. Your gliptins can be combined with the most of the drugs. Your basal insulin can be used in all the OHs. So is it superior over the other available agents of the same class? Or is it affordable? Finally, it is also very important because most of our people, affordability is also a big issue. So the weight reduction, this already I told you earlier. So the maximum weight reduction, maximum HbA1c reduction is seen with the insulin therapy. Insulin therapy. Next to the insulin, it is the diet and exercise. Up to the 2% or 2.5%. Then the metformin and sulfonylureas up to 1.5 to 2%. All other drugs will reduce between 1 to 0.8 to 1.2 or 1.4. See, this is also very important. Anticipated response. See, when you use the secretagogues, long-acting secretagogues, you have to wait for about 7 to 10 days for a better response. And you see whether the patient is responding or not by means of your fasting blood sugars. Rapid-acting secretagogues like your repaglinide. So, immediate response. Again, the postprandial because it acts only on the postprandial hyperglycemia. Metformin, you have to wait for 2 to 3 weeks. Fasting hyperglycemia because metformin will reduce the hepatic glucose output. Glitazones, that is your pioglitazone. Time to response is about 8 to 12 weeks. So 2 to 3 months you have to wait, pioglitazone. So don't express the very good response within the 2 weeks or the 3 weeks. AGA, so they are the shortest acting drugs which acts at the intestines to reduce the intestinal absorption. So they are immediate. DP4 inhibitors, 7 days. SGLT inhibitors, immediate. So few drugs you can have an immediate action like SGLT inhibitors, AGA, and also your secretagogues, immediate secretagogues like your repaglinide. Whereas your long-acting secretagogues or your metformin or your gliptins, so you have to wait for a longer period, maybe 1 week, 2 weeks, or 4 to 8 weeks. Cardiovascular outcomes are very, very important. So a lot of the drugs are there on the cardiovascular outcome trials. These are the different drugs. See the glargine origin trial, CV risk neutral, deglutec, devote, neutral. So all the neutral and the positive you can use it, and negative drugs you should not use it. So exenatide, liraglutide, they are the benefited. Oral semaglutide is the neutral, whereas the subcutaneous semaglutide is the benefit as far as the cardiac function is concerned. So these are the important drugs. We are using the sitagliptin, take-off study, that is the neutral. SAVAR study, saxagliptin, increased heart failure hospitalization. So that is the reason we avoid in cardiac patients. Linagliptin can be used safely, it is a neutral drug. Whatever the dapagliflozin, benefited. So it has a benefit as a cardiac benefit and also renal benefit. So that is a benefited. Empagliflozin is also benefited. So the benefited drugs are SGLT inhibitors and GLP-1 receptors. Fixed dose combinations, advantages, less pills, compliance is the good. So this is authorized conservative management of glycemia earlier, diet, exercise, single drug, double drug, increased drug. Nowadays, no combination therapy from the day one. So this is another case, a 38-year-old lady, history of the GDM 5 years ago. So that means she got the pregnancy at 34 years, high risk pregnancy. That resolved after delivery. So GDM after delivery. Now her fasting blood sugar is 165, PP 196, A1C 7.9, BMI is 26. So she is overweight or the obese with more of fasting hyperglycemia rather than the postprandial. Postprandial is 196, whereas the fasting is 165. That means hepatic glucose output is more. She is obese. So which drug you use? Metformin. Metformin. Already started a metformin 3 times a day, but she has epigastric burning. So what would be your next step? What advice you should give to the GDM mothers? Follow up after 6 weeks, 6 months, yearly. Okay, 6 weeks, 6 months, and yearly once to check whether this fellow is getting the type 2 diabetes or not, because both the mother as well as the offspring born to the GDM mother are at high risk of getting the diabetes mellitus. So most of the GDM mothers, they turn to be the type 2 diabetes in the next 5 to 10 years. So we have to postpone the onset of the type 2 diabetes in the GDM mothers. So usually they gain about 8 to 12 kgs during the pregnancy. So the most important aspect is weight loss. So they have to lose those 8 to 10 kgs of the pregnancy gain in body weight immediately after the delivery in order to reduce the insulin resistance. Otherwise, the resistance will continue and they are going to be the type 2 diabetes in the near future. So metformin is the important drug to cause the gastrointestinal side effects like epigastric burning, etc. So do you use the sulfonylureas here? Not of much use. Sulfonylureas. Pioglitazone, not of much use. Alpha glucosidase inhibitors, here the postponement is very low, not needed. SGLT inhibitors, you can continue. You can continue. Okay. Or the gliptins also you can use them. So another case, a 60-year-old female, diabetes for 10 years. So she got the diabetes at the age of 50 years. She has been on metformin 1000 milligrams twice daily. That means 2 grams metformin a day. Glimepiride 2 milligrams twice daily. That means 4 milligrams a day. Pioglitazone 15 milligrams. She is on sulfonylurea, metformin, and glitazones. BMI 30. Age 60 years. So obese. Latest HbA1c 8.4 in spite of the 3 drugs. Has been above 8% for almost the 1 year. So it's very high risk of getting the vascular events. At 60-year-old, post-menopausal woman, 3 drugs, still HbA1c more than the 8.5. So high risk of getting the myocardial infarction or CVA, etc. Increased dose of pioglitazone caused her to gain over 7 kgs. So I told you, pioglitazone will increase the body weight. So physical examination unremarkable for a palpable thyroid and the varicose veins. So because of the obesity, etc., hypothyroidism is also there. Fasting blood sugar 140, 2 hours PP 240. So 140, 240. So what are her treatment options? So what is the working diagnosis here? So type 2 diabetes, postmenopausal, obesity, 3 OHS, still HbA1c is more than 8%. And pioglitazone causing weight gain. So first what to do? Stop pioglitazone is the first answer. And then why don't you stop the glimepiride also? Okay. So stop the glimepiride, stop the pioglitazone. Continue the metformin. So you can add other drugs like your SGLT inhibitors or the gliptins, etc. So that finishes our talk today. See, algorithms and guidelines are of no use. They are of no use if the patient does not comply with the diet and exercise recommendations. This is very, very important. Diet and exercise. Does not comply with the medication. So compliance is very important. Does not follow up the regular. So follow up is very important. Okay. So drug compliance should be there. Follow up should be there. And diet and exercise. So patient education is the key to success of any diabetes care program. So next module. So what is this? Lot of numbers here. Sodium, potassium, sugar 789, 798, 798. 86-year-old male brought to you in a drowsy state. He is on diabetic and glyphosate and metformin. Patient is drowsy, dehydrated. So complications, diabetic. Maybe upper one is the HSS. Okay. The lower one, 14-year-old boy brought unconscious to you. He is not known to have diabetes. No history of diabetes. Attendance give history of polyuria and polydipsia for the last 2 weeks. Last 15 days, polyuria and polydipsia. Boy is in unconscious state. What is the blood sugar? 522. 520. So in all dehydrated individuals, especially pediatric, dehydration without gastroenteritis, please think of diabetic ketoacidosis. Okay. So here the sodium 137, potassium 135. So electrolytes also very important in DKA management. So the second one is DKA, upper one is HSS. So learn the answers to these questions much more in module 6. So next class will be on metabolic complications of the diabetes or acute complications of the diabetes. Now question and answers. Which of the following insulin has the longest duration of action? Deglutec, about 36 to 40 hours. Good. Which of the following is a short-acting insulin analog? Glargine is long-acting, detemir is long-acting, deglutec is long-acting. Glulisine. What are the other short-acting insulin analogs? Lispro and aspart. Okay. Lispro, aspart, and glulisine are the short-acting. Which of the following drugs is the best choice for combining with the insulin? Good. Metformin is the good drug to be combined with the insulin. A patient is found to type 1, we use only insulin only. No. Initial days we don't use the metformin, but after 5 years, 5 years or 10 years of type 1 diabetes, they become obese. Okay. Then there is the insulin resistance also in them. In such situations, obese type 1 diabetes, there is a role for the metformin. But initial days, no role for metformin because metformin is more harmful also. So that causes more metabolic acidosis or lactic acidosis. A patient is found to have a fasting blood glucose 220. NPH in the bedtime. Check the blood glucose at 3 a.m. twice and values are 140 and which of the following is appropriate adjustment to his regimen? Increase the dose of the morning. Increase the dose of the night NPH. That is the right answer. Which of the following reasons can reduce HbA1c to the maximum extent? HbA1c. So highest is the insulin. Next is diet and exercise. And then metformin and glibenclamide. Or that is your sulfonylureas. So here a DAPA will reduce 1.2 or 1.3. CETA maybe 0.8 to 1.2. Pioglitazone maybe 1. Glimepiride 1.5 to 2%. Okay. So right answer is D. So a patient is on 1 mg glimepiride, 1000 mg of the metformin daily. Blood glucose is not under control. A1C 8.7. Advised to increase the dose of the glimepiride to 2 milligrams and to add pioglitazone 15 mg. 3 days later, the patient reports recurrent symptoms of hypoglycemia. So what is the most logical line of management? So hypoglycemia is because of sulfonylureas. Okay, not with the metformin or not with the pioglitazone. So stop pioglitazone is not right. Reduce the dose of the pioglitazone is not right. Reduce the dose of the glimepiride back to the 1 mg. Suppose if the patient gains body weight about 8 kgs or 10 kgs, so then you can stop the pioglitazone. Good. A patient has fasting and postprandial blood glucose values 105 and 216. A1C 7.3. Is on combination treatment with the glipizide 5 mg BD and metformin 1 gram BD. What would be the best option to add to his regimen in order to bring the HbA1c below 7%? Because our goal is 6.5. Okay. So fasting is 105. POP is 216. So here elevation is more of postprandial. Postprandial elevation is not very high because A1C is also only 7.3. So your goal is just reduction of the 0.5 or 0.6. Okay. Increase the dose of the sulfonylureas? No. Increase the dose of the metformin? No. Add pioglitazone? No. Right answer is O-glucose. So why O-glucose reduce the postprandial hyperglycemia only 0.4 to 0.5. Which of the following conditions is an indication for initiation of the insulin therapy? Recently diagnosed diabetes? No, not all recently diagnosed diabetes. They don't require medication also. Recently diagnosed individuals. When the fasting blood sugar is 130, postprandial blood sugar is 220, when the patient is a little bit overweight or the obese, don't give any drugs. Just diet and exercise. Finish. Stable angina and effort. Don't require any insulin therapy. Elevated urinary albumin excretion. Pregnancy is a big indication for insulin. Which of the following is a cloudy insulin preparation? See, in fact, no, these are all indicated for the insulin. On the other side of the coin, in all the situations, you can start the insulin. Recently diagnosed diabetes with fasting blood sugar 300, postponed blood sugar 450. So what is your answer? Yes. Stable angina and effort with the hypertension, with the dyslipidemia, with the smoking, and already father died at the age of 50 years with acute myocardial infarction. This guy with a stable angina and effort. So do you start insulin or not? Yes. Elevated urinary albumin excretion along with urinary tract infection. Ultrasound shows pyonephritis. So do you add insulin or not? So all these are indications for, but book says that in pregnancy, insulin. Even in the pregnancy, we use only 5 to 10% diet and exercise. In almost 40%, we treat with the metformin. Even if they need the insulin, just 4 units or 5 units or 6 units before the lunch and before the breakfast, we can control the GDM very effectively. See, this is about the GDM. There is a second half of the pregnancy. If the diabetes occurs in the first half of the pregnancy, yes, definitely we need the insulin. Here pre-gestational diabetes. Okay, then the definite answer is the insulin. Okay. Which of the following is a cloudy insulin preparation? Cloudy. NPH is a cloudy. Glargine is clear. Regular is clear. Aspart is a clear. So which of the following anti-diabetic is recommended as a first line of drug for treatment of most patients with type 2 diabetes? So metformin. So thank you very much. Excellent.